Hello everyone, welcome to Patho Excellence. In this endometrial pathology video series, today we explore two fascinating endometrial lesions, the endometrial polyp and atypical polypoid adenomyoma or APA. Both appear as polypoidal growths within the uterine cavity, yet their microscopic differences hold the key to diagnosis. Let's look closer at the morphology, histologic features, and diagnostic clues that help us differentiate between the two under microscope. So, first of all, endometrial polyp. So, what is the definition? Is polyps are benign, pedunculated, or sessile growths with no malignant potential. They are localized overgrowth of endometrial glands and stroma, forming a polypoidal mass projecting into uterine cavity. Etiopathogenesis includes hormonal imbalance, mainly estrogen predominance, seen with tamoxifen therapy, which is used in breast carcinoma patients, which is selective estrogen receptor modulator. Abnormal response to endometrium to estrogen leads to localized hyperplasia and some chromosomal rearrangements. Gross features, if we see, they are either single or multiple, sessile or pedunculated, soft polypoidal, having smooth surface, size ranging from few millimeter to several centimeter, cut surface generally grey-white to reddish due to vascularity and may protrude into the cervical canal. Here the section, the specimen shows, this is the hysterectomy specimen containing a small polyp arising from the fundus of the uterus, and it is having a smooth surface. So it is easy to diagnose when there is a hysterectomy specimen. But when we receive dilatation and curettage specimen, generally polyps are fragmented and removed piecemeal, and so it can be difficult to recognize. Now microscopic features. This is larger tissue fragments, polypoid in shape, and surface epithelium is on three sides of the polyp. So it is covered by endometrial epithelium, may be atrophic, but often it is proliferative even in postmenopausal women. Now papillary proliferations with fibromuscular core occasionally occur on the surface of an endometrial polyp or within cystically dilated glands. It may exhibit a degree of atypia, often with degenerated appearing nuclei and sometimes hobnail cell change. And reactive surface changes can be seen, including ulceration or breakdown and hemorrhage. So here we can see a scanner view of a whole polyp, which is having outer surface epithelium on these three sides of this polypoidal growth. And this yellow arrow shows fibrovascular core. The polyp contains irregular shape and uh, varying size and cystically dilated glands in background of fibrotic stroma. So this is a characteristic of polyp microscopically. So as we have seen, glands are mainly cystically dilated or crowded. Variable morphology includes some having proliferative features or some having secretory features. They are lined by either normal or hyperplastic or atrophic epithelium. Polyp originating at the junction of upper endocervix or lower uterine segment contain both the epithelium, endocervical as well as ciliated lower uterine segment type of glands. And they may exhibit metaplastic changes including ciliated, eosinophilic, mucinous and squamous metaplasia. This is stroma. So it is dense fibrous stroma rich in collagen with abundant extracellular connective tissue. It can contain variable amount of edema, myxoid change, and hemosiderin-laden macrophages. Bundles of smooth muscles within the stroma may be present, and it is often in the close proximity to thick-walled blood vessels. So, adenomyomatous polyp, as the name suggests, adeno means gland, myomatous means muscle tissue in polyp. So, only if we see endometrial polyp, it is having generally fibrotic stroma, gland, and thick blood vessels. While if adenomyomatous polyp, if it is containing all the features along with the smooth muscles. So, foci of decidua may be present, usually reflecting exogenous progestin use or pregnancy, and mitotic figures in the stromal cells may be present in some cases. And the fourth component is blood vessels. And thick-walled vessels are hallmark features for any polyp, and ectatic thin-walled vessels may be seen. So generally, polyp is composed of four components: outer lining surface epithelium, then glandular component, stromal component, and fourth one is blood vessels. Now, for practical purposes, these polyps are divided into benign polyps and the atypical polypoid adenomyoma. So, benign polyps are again having five morphological features. First is proliferative or hyperplastic, second atrophic, third is functional, mixed endometrial and endocervical, and adenomyomatous type. So as the name suggests, proliferative or hyperplastic means the glands in the polyp are having features of hyperplasia and generally gland to stroma ratio that exceeds 2:1 within an extensive area of the lesion. Atrophic, as the name suggests, the lining is like a postmenopausal women showing atrophic gland. Functional may be either secretory phase or proliferative phase gland, and mix, as the name suggests, endometrial as well as endocervical, both the glandular tissue are present in single polyp. Mostly they are located at the lower uterine segment. And adenomyomatous means adeno and muscular tissue, fibrous tissue, blood vessels. So these are the five morphological forms. And second is the atypical polypoid adenomyoma, which represents a distinctive form of polyp that should be segregated from the variants of common polyp. So this we discuss in later on in next few slides. So next is tamoxifen associated endometrial polyp. This show fibrotic, sparsely cellular stroma, metaplastic glands, and mucinous metaplasia, edema, decidualization or myxoid change, periglandular stromal epithelial metaplasia, and shading. And staghorn shaped glands, which are dilated glands with stromal projections within their luminal spaces. And these glands are polarized along the long axis of the polyp, and there is periglandular stromal condensation in the absence of conspicuous mitotic activity are reported. And there may be multiple and can reoccur. Right? So, fibrotic stroma, metaplastic glands, staghorn-shaped glands with a polarized along the long axis, mitotic activity is generally low, and periglandular stromal condensation. So, these are the features in the tamoxifen-associated endometrial polyp. This treatment is mainly for the breast carcinoma patient. Other rare findings that we can come across in polyp is tuberculosis, placental site trophoblastic tumor, some B-cell lymphoma, metastatic malignant melanoma, sarcoidosis, and metastasis of various carcinomas developing in endometrial polyp, which include CA cervix, stomach carcinoma, gallbladder carcinoma, bladder carcinoma, etc. So now, if we see microscopically, this is the benign endometrial polyp showing large polypoidal tissue, and surface epithelium is covered by thin layer of cuboidal gland, and it is whole polyp is covered with this surface epithelium, and the glandular tissues are irregularly shaped. Some of are having round tubular in shape. If we see blood vessels, this is the hallmark feature. This is a thick-walled blood vessels, which is uh, showing congestion. So many thick-walled blood vessels and fibrotic stroma. Right. So this is because some of the glands are showing proliferative activity. So this is called proliferative or hyperplastic endometrial polyp. Again, in high power view, we can appreciate both glands and blood vessels. So blood vessels, they are thick walled. We can easily appreciate the wall thickness is very much high, and lumen contains RBCs. So number of blood vessels showing thick walled appearance, and these are the glands showing irregular shape, and some of having proliferative activity, and this is fibrotic stroma. So this is high power view again. See, this is the large vessel, and the wall is thickened with RBCs into the lumen. And these are the fibrotic and muscular stroma in case of polyp. Again, large polypoidal tissue. Here there is stalk to which this polyp is attached to the endometrium, and surface epithelium, it is visible here. Some of area is devoid of surface epithelium. Glands are mainly cystically dilated, varying in size and shape, and uh, this is called cystic atrophic gland, and some of the glands small in size, showing proliferative activity. So it mimics hyperplasia. So this is proliferative or hyperplastic endometrial polyp. Here, a high power view of a section shows these are the crowded secretory glands, which uh, contains vacuolization inside the gland epithelial cells, and this here we can appreciate this gland showing some part of the cell, some part of the gland shows vacuolization, and some are having a inactive epithelium. So this is functional polyp showing secretory activity, and this is the stromal component. Few dilated blood vessels or thin walled vessels are also present. Here the characteristic feature is the surface epithelium, which is not visible properly here, few cystically dilated gland, few inactive round tubular gland, and important thing is fibrotic and hyalinized stroma. So this is hyalinized and dense stroma in the polyp. This is a section showing most of the glands are cystically dilated, and they are lined by cuboidal epithelium. So this is atrophic polyp, and stroma is showing fibrotic in appearance. Here endometrial surface polyp showing surface epithelium which is visible properly here, and beneath the surface epithelium these are the dilated and ectatic vessels, few small vessels here, dilated vessels, and some of the vessels are associated with the extravasated RBCs. So extravasated RBCs means they are scatteredly seen in between the stromal tissue. And these are the glands showing proliferative activity, and here we can appreciate fibrotic stroma. So this is an example of ectatic vessels in benign endometrial polyp. Here this is a polypoidal structure and this is a normal endometrial tissue. This polyp shows irregularly placed increased number of the glands, fibrotic stroma, and important feature is this is called extensive squamous change inside the glandular epithelium. So here we can appreciate squamous metaplasia in most of the glands of this polyp. So this is the example of benign polyp with squamous metaplasia. Here few glands are cystically dilated. This is high power view, a very clear picture showing a polyp having surface epithelium. This is gland. Some part of the gland shows epithelium with squamous change. So these are the components showing squamous metaplasia, and this is normal glandular epithelium. Here also we can appreciate whole gland lumen is filled with the squamous metaplastic cells, and this is the atrophied gland. So this is an example of benign polyp with squamous metaplasia with hemorrhagic and stroma and few dilated and ectatic vessels. So these are the vascular area. This is hemorrhagic stroma because RBCs are there inside the or in between the stroma. This is again a low power or scanning view of polyp which shows entire polyp surface showing in areas of infarction. So this is the infarcted endometrial polyp. Outer surface, because of there is either polyp is infarcted because of some injury or due to decrease in vascular or blood supply will lead to endometrial polyp infarction, and these are the cystically dilated or atrophied gland into the polyp. This section shows glandular nuclear atypia into the in a polyp. So this is the gland. Here we can see atypical cells in the polyp, and this may raise the concern for serous endometrial intraepithelial carcinoma. So to differentiate it from this endometrial intraepithelial carcinoma, we can use Ki-67 and P53 immunostain, which is useful in this scenario, since if there is carcinoma, then there is high proliferative Ki index and typically display an aberrant P53 immunohistochemical staining pattern. Here, this case shows the atypia was of degenerative nature. So likewise, you can appreciate atypia also in some polyps. Some mimics are there, some like polypoidal endometritis, in which the epithelium of endometrium take the shape of polyp, which is not true polyp, and Here we can see extensive acute and chronic endometritis or acute and some dilated blood vessels and fibrotic stroma infiltrated by here chronic inflammatory cell infiltrate, which is nothing but the inflammatory pseudopolyp. So extensive acute and chronic endometritis may occasionally present as an inflammatory pseudopolyp. Second example which mimic endometrial polyp is polypoidal exogenous hormonal effect. Here this polypoidal structure is due to excessive progesterone if given to patients, which leads to extensive stromal decidual-like change, and this fragment of endometrial tissue may acquire a polypoidal shape, and these glands are inactive in nature. This is the uh, mimic of polyp, but here the characteristic vessels or thick-walled blood vessels of polyp are lacking. So this is the polypoidal exogenous hormonal effect. Third is endometrial basalis. Endometrial basalis is normally containing thick-walled vessels and mainly irregular proliferative glands. So here dense stroma, prominent thick-walled vessels and irregular glands are there, but what it lacks is surface epithelium. There is no surface epithelium present over this tissue bit. So this is a endometrial basalis and not a true polyp. So we have seen benign endometrial polyp, 5 types: functional, proliferative, atrophic, mixed type, and adenomyomatous. Now, atypical polypoid adenomyoma, which is APA. As the name suggests, atypical means here we have to look for atypia in the glandular epithelium. Polypoid, it is polypoid in nature, in appearance, so we have to differentiate it from endometrial, benign polyp, and adenomyoma, means glandular as well as smooth muscle presence in this polyp. So by definition, it is rare benign but pre-malignant endometrial lesion composed of endometrial glands with atypia and fibromuscular stroma in polypoid architecture, and it is considered as a precursor lesion for endometrial adenocarcinoma. Now epidemiology, it is mostly in perimenopausal women 40 to 50 years associated with unopposed estrogen exposure, including causes obesity and ovulation or PCOS, can occur in younger women, important because of fertility issues. Clinical features, generally patient presents with AUB and sometimes detected incidentally on hysteroscopy and may mimic endometrial polyp or submucosal leiomyoma clinically. Gross features, it is polypoidal in nature, projecting into uterine cavity, size 0.5 to 5 cm, form white to tan, cut surface, and microscopic features contain key triad including endometrial glands with cytological atypia. It resembles atypical hyperplasia, so we have to differentiate it from EIN or atypical hyperplasia with the help of microscopy. Second, irregular crowded glands and nuclear atypia. Second component is fibromuscular stroma. So, muscular tissue is also present in normal myometrium or in adenomyomatous polyp. But in this area, we can see elongated bundles of smooth muscle cells and the characteristic short interlacing bundles of smooth muscles intermixed with endometrial stroma is present in APA. So normally They are elongated bundles, but in APA there is short interlacing bundles of smooth muscle and distinguishes it from typical hyperplasia or carcinoma. Polypoidal architecture, lesion projects into the endometrial cavity. Mitotic activity may be seen and it is up to 2 mitosis per 10 high power fields. No destructive stromal invasion present which helps rule out carcinoma. So, ATPI is there but without any stromal invasion. Right? Now, how will you diagnose or what are the features that favor cytological ATPI and APA? So these are haphazardly arranged but not markedly crowded or back-to-back appearance of glands. Right? Second, cells of the glands have enlargement, stratified, rounded nuclei with vesicular chromatin pattern and prominent nucleoli, which is similar to the glands of atypical hyperplasia. A very characteristic, though not specific feature is presence of squamous metaplasia, in which central non-keratinizing nest of squamous cell shows central necrosis in between the or inside the squamous nest. So this is a case showing atypical polypoid adenomyoma. Here we can see irregularly placed atypical haphazardly distributed endometrial glands and smooth muscle in between or encircling the glandular tissue. So this is short interlacing fascicle pattern in the APA. Here high power view C is shows squamous metaplasia characteristic features for APA, glandular tissue showing atypia and proliferative activity back-to-back arrangement at some places, and smooth muscle are present surrounding the glandular tissue. And here these cytosquamous cells are cytologically benign and it may sometimes obscure the cytology of other glandular tissue. This is again a case of APA. Here, haphazardly arranged glands. Some area shows back-to-back arrangement, and these are the short interlacing fascicle of smooth muscle cells. And here there is squamous metaplasia, and centrally there is presence of necrosis. So this is squamous morule containing central necrosis. We can here appreciate high power view. Here, squamous metaplastic change. These glands are back-to-back arrangement, having back-to-back arrangement, some nuclear atypia, and smooth muscle fascicle surrounding the gland. So this is again atypical polypoid adenomyoma. So now we have seen morphology of endometrial polyp and atypical polypoid adenomyoma. So how will you differentiate this from atypical hyperplasia or EIN or endometrioid carcinoma? So grossly, these two are polypoidal in nature, while atypical hyperplasia or endometrial intraepithelial neoplasia shows diffuse thickened endometrium, and here there is polypoidal mass or tribal or infiltrative tissue. Glands are normal or cystically dilated. Here it shows cytological atypia. Here crowded but back-to-back arrangement, and these are glands atypia with invasion. Stroma, mainly fibrostroma with thick walled vessels. Here fibrostroma with muscular tissue, and here endometrial stroma is present, no fibromuscular component present. Endometrial carcinoma mostly showing desmoplasia or it is replaced by mainly malignant glands. Atypia absent in endometrial polypoid present in all these three conditions. Invasion, if present, it is endometrial or endometrial carcinoma. Here there is no invasion at all. In ATPA or atypical polypoid adenomyoma, there may be pushing margin but no destructive invasion. So what are the key features in all four? So polyp, as we have discussed, is a gland, fibrostroma, thick walled vessels, while here polypoidal lesion, atypical gland, fibromuscular stroma, here crowding and cytological atypia but no invasion. Here stromal invasion is confirmed, confluent glands and necrosis. So as the name suggests, endometrial polyp benign, it is low risk for malignancy, moderate in APA, and high possibility is atypical hyperplasia or precursor to carcinoma. And this is the last one is the malignant lesion. Now management by polypectomy in benign, but if it is APA, then hysterectomy in older patient. If it is fertility sparing is required, then excision is common. Here progestin therapy or hysterectomy, and in case of carcinoma, surgery plus or minus adjuvant therapy. So I hope now you can easily appreciate endometrial polyp, APA, atypical hyperplasia, and when you see the slide under microscope or when you suspect endometrial polyp, you have to see for the all the component of polyp, whether they are showing hyperplasia or functional activity or any atrophic component, and whether they contain cytological atypia or not. So, as we have seen, both lesions may look similar grossly, but microscopic architecture tells the real story, right? So, recognizing the fibromuscular stroma and atypia is crucial for accurate diagnosis and preventing misinterpretation. If you found this helpful, don't forget to like, share and subscribe for more in the endometrial pathology series, and join our Telegram channel for updates. Link is given in the description. So thank you. In next topic we will discuss metaplasia and endometrial hyperplasia. So stay tuned.